Welcome, my dear students, to a series of charts in hematology, in which I shall be dealing with the university questions. It is not just from a practical point of view, but I would like to summarize the theory points in a chart. Let us see what best we can do in this particular chart on iron deficiency anemia. With this introduction, I shall be going to the explanation proper. In hematology, there are two things which are of paramount importance. We cannot ignore them at all. One is the peripheral smear, two is the bone marrow smear. Now, what I am showing you people is a normal peripheral smear in which the RBCs are more or less equal, and then there is a central area of pallor which is not exceeding 1/3 of the diameter. Take this cell, for example, there is a hemoglobinization, pallor, hemoglobinization, almost equal to each other. So this is a normocytic, normochromic RBC. The smear is normal as far as the RBCs are concerned. With this, we shall go to the slide on iron deficiency anemia. You can take any of the pictures, but these two, let us take first for comparison. In this one, so there is a lymphocyte. The RBC is supposed to be around the size of a large lymphocyte, but here obviously it is smaller. One. Secondly, I find that there is an increased amount of pallor. How do I know that it is pale? Compare it with the peripheral rim of hemoglobin. So you will be able to know that there is increased pallor. So the RBCs are obviously microcytic, severely hypochromic. And in this particular one, there is an exact opposite of it. The cells are larger and there are large teardrop cells. There are some oval cells, or we call them as macroovalocytes. Look at this one, it is quite large in this. So it can be a macrocyte. This picture, on the contrary, it shows a various plethora of shapes in the RBCs. This is a teardrop cell. As though the cell is crying, you find that there is a teardrop form, an elongated or a pencil-shaped cells. And these, the text used to describe as the ring or the pessary cells, contraceptive device. And the RBCs on the whole are microcytic, hypochromic with moderate to severe anisopoikilocytosis. Sometimes there can be target cells. This again is microcytic, hypochromic. We should be very careful because there is one differential diagnosis, namely beta thalassemia, which will be having exactly the same picture. But the patient will be a child and there will be a history of jaundice. This is a wonderful line diagram that has been picked up. You people can draw. There is an increased amount of pallor and the cells are varying sizes and shape. Microcytic hypochromic. So we have finished the normal blood picture. Once there is a blood picture that is over, I will go to the bone marrow picture. Bone marrow is not very important as far as the RBCs in rather the iron deficiency anemia is concerned. Normally in a bone marrow, there are certain sets of headings which I shall be repeating any number of times. 1. Cellularity. 2 will be erythropoiesis. 3. Granulopoiesis. 4. Megakaryopoiesis. Lymphocytes and plasma cells. Mitotic figures. Myeloid erythroid ratio. Abnormal cells, etc. So these I will be repeating. But in a case of iron deficiency, we will stick to only the normoblast. The counterpart of the microcyte will be the micronormoblast. So there is a defect in the hemoglobinization as far as iron deficiency is concerned. Therefore, the cells also lag behind. They are small and they are called as micronormoblast. Always, my teacher used to say, identify a cell by the company it keeps. All these have originated from a single colony forming cell, so they are all together, just as you students of a college are. So this will be the bone marrow picture. So it can be normocellular or hypocellular micronormoblastic pattern of maturation. WBCs and platelets need not be affected. And myeloid erythroid ratio can be increased. This is a wonderful picture from LME, courtesy, and in which I am finding blue patches all over. This is called a Pearl's Prussian blue, capital PERL apostrophe S. Pearl's Prussian blue stain, which stains the iron as blue. This one you people should answer. So in a case of normal or in a case of hemolytic anemia, you find that the iron stores can be increased, whereas in a case of severe iron deficiency anemia, it is almost depleted. And this is the grading. You people can know that it varies from 0 to 6. 6 and 5, there are heavy to very heavy grades. And there are floccules of iron that are seen in the bone marrow. This is the pattern which we use to describe and to distinguish from the other types. Also, we will be using it to assess the response of the patient to treatment. Lab diagnosis. Lab diagnosis is a very important component which we tend to misunderstand rather than understand. A lab diagnosis will include the general hematological investigations, the peripheral smear, the bone marrow smear, and also any other special investigation. In our case, you find hemoglobin can be reduced. Normally, it is about 12 to 15 grams. Here, it can be as low as 2 grams to 6 or 7 grams. That is the usual range that we see in a case of moderate to severe iron deficiency anemia. NCV, mean corpuscular volume, is reduced. It can be as low as 60 femtoliters. Mean corpuscular hemoglobin is also reduced. And the other parameters will be serum ferritin. There is a normal range in this table, and this is the value in our iron deficiency anemia. Whether you people know the exact numbers or not, that is a different matter. But please do understand that in the first 3, there is a reduction in a case of iron deficiency, and in the last 3, there is an increase in the case of iron deficiency. This one you people shall be memorizing. Total plasma ion binding capacity, it is increased. Transferrin receptor, it is increased. Red cell protoporphyrin is increased. Whereas the serum transferrin, serum iron, and serum ferritin are all reduced when compared to the normal values. So I hope you people will be able to answer all these things. What else is left? This is the clinical picture. Clinical picture of anemia. Always be careful if you are going to get a 10 mark or a 15 mark question. The clinicals can fetch you not more than 2 marks. Do not spend your entire time. At the same time, they can come as MCQs. So in this case, I am finding a spoon-shaped nail, a koilonychia. My professor of medicine used to say, place a drop of water on it and it will stand. The nails are lusterless. They are brittle. They are concave or spoon-shaped with longitudinal ridges, and they will be having some amount of brittleness. So there will be 5 qualities in a case of a koilonychia. Loss of shine, pale, brittle, longitudinal ridges, and spoon shape. And you find that the conjunctiva, this is one region which the doctor will usually assess. Nowadays, even doctors are anemic. That is a different story. So you find that the conjunctiva is pale, whereas it will be yellow in a case of hemolytic anemia. And this is the picture of a post-cricoid web. The patient can develop a esophageal web or a post-cricoid web, which is called the Plummer-Vinson syndrome or the Patterson-Kelly syndrome. So these can be asked as questions. Otherwise, you answer, you score a point. Finally, I will go to the absorption of the iron. There are two types of iron, and this particular region is supposed to be the gastrointestinal tract. And this is the duodenal enterocyte. So there are two forms of iron, the heme iron and the non-heme iron. So, and what happens is the Fe3 plus is converted to Fe2 plus. Ferric is being converted to the ferrous form, in which you find it is being absorbed into the duodenum. And there will be a transferrin that is there, which is carrying it to the blood. Also, you find that there are other components such as hepcidin, which will impede the absorption when the store is adequate, or there can be a hepcidin which will be promoting it. These things we people should know. And there is something called a glucosal block theory, which you people would have read in your biochemistry. So you people should be mentioning the clinical features and then the absorption of iron, what will be the blood picture, what are the other laboratory findings, what is the bone marrow picture, what is the stain that is used for it, and what is the differential diagnosis, including a beta thalassemia. I would like you people to kindly go to these references. R.A.T.S, I have taken a complete class on iron deficiency. Please go back to it. Again, I would have mentioned the chart as well as the slide on it. One page is a book written by me, and it is a superb, concise book. In fact, it is called one page because each page has a content. And the question can be in the form of essay, chart, slide, viva oversee, short notes, MCQ, and whatnot. I hope you people have visualized everything in this field. From the normal smear, the peripheral smear, the difference with the macrocytes over here, and then what are the various morphological abnormalities, how do you stain and look for the iron stores, the grading of it, and then the clinical presentation, apart from this pallor, breathlessness, etc. Those things again we shall visit, but kindly go back to these references. This will be your pillar for the examination. The theory class and R.A.T.S and the one page. Thank you.